Hi, everyone. If the tech is working, you're now watching us through Facebook Live, through YouTube Live, and on Twitter. And if all goes well, I should be able to see your comments. So for those of you who got confused by the time zones, and the software did too, I apologize if you've been on for a while, but welcome. We're here. This is our first Free Speech in Medicine live stream. Our organization has been running for approximately 2.5 years. Just to briefly explain, we were somewhat, I suppose, a response to COVID, but many of us in medicine felt the walls of free speech closing in for quite some time. So this is not just about COVID by any means, as you'll find out tonight. One of the things that's been happening in medicine and in medical education is the insertion of what we call politely diversity, inclusion, and equity, DIE. What would you say, priorities into the whole process of medicine, into the doctor-patient relationship, etc. And we're now moving towards teaching those as formal. So this has been happening implicitly for some time. We've all seen it happening. And now recently, the Royal College of Physicians and Surgeons of Canada, through their what they called expert working groups that are setting out the educational guidelines for 2025 and later, have said the quiet part out loud. They've said that diversity, inclusion, and equity has to be preferenced ahead of medical expertise. So this is called the CAN-MEDS framework. So CAN-MEDS are the objectives that all specialist physicians get trained by according to these objectives. And just to pull out one quote, which gives you a flavor of what's going on. The people from the expert working groups who came up with a report on this said, while introducing these new competencies within CAN-MEDS would be a small step forward. So these competencies are things like what they call anti-racism, social justice training, etc. This would be a small step forward, but a more effective way to demonstrate the fundamental need for anti-racist and anti-oppressive praxis would be a complete reimagining of the CAN-MEDS framework to raise awareness that it was grown in the soil corrupted by racist elements. So the idea here is that the entire process of medical education up until now, up until they change it to be correct and new, it's all been racist. Many of us are concerned about this, and to discuss just why, I've assembled a very, what would you say, esteemed panel of medical experts. All of these people are specialist physicians here in Canada. Our lead-off speaker is Dr. Pooya Kazemi. Pooya, let me I'm just going to pull this up. Pooya is originally from Iran, and he moved to Canada in, I believe, and he can correct me if I'm wrong, but he moved to Canada in 2012-ish, and he attended UBC. Pooya, I might be wrong. I think at the age of 12. So he's going to correct me when he comes on. But Pooya trained at UBC. He went on to do anesthesia, and he now lives in Victoria with his wife and 3 kids. I've been a big fan of Pooya. He's been outspoken since the beginning of COVID. He's someone who seeks the truth, and he's talked about such important issues as lockdown policy, vaccine policy, etc., and written some important op-eds, including in the National Post and other national publications. So Pooya is going to speak first. Martha Fulford, some of you may know. Martha is a recently mostly retired infectious disease specialist who works out of Hamilton and worked at McMaster. She's currently still practicing as a locum physician, but is mainly retired. Martha came to prominence during COVID because she kind of refused to toe the party line on COVID policy. There's some wonderful videos of Martha and she does a great job of speaking out and what would you say, countering the narrative. She was one of the very early people to do that before many of us kind of jumped on board with her. Martha was out there. So thanks to Martha for joining. Our third colleague joining us today is Dr. Roy Eappen. Roy is an endocrinologist. He's located in Montreal. He has been as well very outspoken in various ways. He's politically involved. He's become very involved with the trans issue, both, what would you say, nationally and somewhat internationally. Roy has joined the Do No Harm group, so you can look up donoharmmedicine.org. And Roy is a fellow of Do No Harm, and he's done some great work with them, including penning a very viral op-ed for the Wall Street Journal on the trans issue a number of months ago, and then another more recent one. So Roy is a really important voice speaking out against a lot of craziness going on, including this subject tonight of identity politics and its creep into medicine and medical education. So you'll have to forgive me. I'm new to the tech here, and I'm trying to juggle a bunch of papers and people, but I'm going to bring our panelists to the fore, so you should be able to see them. And as I mentioned, we are going to start with Pooya. And Pooya, I got to apologize. So I dropped my papers and I was trying to sort them out as I was speaking. You'll notice I was a little flummoxed, but you can fill in a little bit about your bio. And as I understand it, that will lead into what you want to tell us about tonight. So thanks for joining us, and please go ahead.
Thanks, Chris, thanks for having me on this panel to discuss this important topic. Before we start, somebody's asking if there could be a link to the Royal College documents, the draft documents. I don't know if anybody has that and can share that. Oh, there we go. There's Dana Churchill shared that. Okay, that's nice. So yeah, my name is Pooya Kazemi. I'm an anesthesiologist working here in Victoria. Chris eventually got it right. I did move to Canada at the age of 12 back in 1995 with my family to escape the authoritarian Iranian regime, which everyone has probably heard of in the news, especially with recent events. Before I start, I just want to do the usual disclaimers. What I'm going to express tonight are my personal opinions, not that of my employer, university, or my anesthesia department. But having said that, I think a lot of us, a lot of the physicians that are around me who I've spoken to have expressed quite a bit of concern about the changes to the CanMed's roles. In fact, I would say a good chunk of our anesthesia department, if not the majority, agree with the people at this table. Some of us have expressed ourselves through letters and feedback to Royal College. We actually have written a letter on behalf of some of our department members. We've written a letter to Royal College, and some are just kind of more silent. And what's kind of concerning about the silence is that, and what's really worrisome is that some of the physicians are actually silent because they're fearful. There's a few physicians we're speaking to who said they rather not speak because they have children and a mortgage. And that's just not the culture we want to live in. This is not the Canada that I know. That's not the Canada I moved to in 95 as a 12-year-old, where my family was seeking freedom, ability to express ourselves, to have free speech, to engage in respectful dialogue. So to live in fear of being able to express your opinion, and an opinion that actually appears to be a majority opinion, that's really concerning and has no place in this country, in my opinion, anyways. It's often said that the road to hell is paved with good intentions. And I do want to emphasize the good intentions. And I'll use the Iranian Revolution as an example. So, my parents went through the Iranian Revolution. I was born right after that into the Iran-Iraq War. But in 1979, there was you could call it a moral panic. And people in the country were fed up with the monarchy and the Shah of Iran, who was not a nice man, an oppressive regime, not necessarily democratic. However, probably better than what we have now. So what ended up happening is that a revolution happened with three main promises. And just want to emphasize what these promises were, and you compare and contrast to what you're hearing today in 2024 in Canada. So number one, social justice. Number two, freedom. Number three, democracy. Those were the promises that were given to the Iranian people at the time of the revolution. And the rest is history. So the Shah was removed, and again, not supportive of the monarchy per se, and there was definitely lots of flaws of that regime. But instead, we now have an authoritarian, oppressive, chauvinistic regime who, engages in public hangings, persecution of minority groups and women, etc. So again, they promised social justice, freedom, democracy, and they delivered none of that. And instead, it's a place where many people are trying to run away from. And I won't say too much more about that. But again, it started with good intentions, right? People were fed up with the monarchy, with the Shah. There was problems right in the country, and people want to change. And so we have kernels of truth as well right now. We have a history of discrimination, racism. Some minority groups have suffered greatly in the past in North America and many other Western nations. But we've also made a lot of progress. The question is, with the ongoing problems that we do have existing, let's say socioeconomic divides, some remaining racism, etc., is the solution DEI, or are there more, or are there better solutions that we could use to address the remaining problems? And I don't think DEI is the solution. I don't think identity politics is the solution. So we're starting with problems, but our solution appears to be the wrong one, which I think, in my opinion, will create more problems. There's also seems to be a problem with sort of where the claims that are being made or the truths that are being shared. For example, we'd repeatedly hear that Canada is a white supremacist racist country. Yet when you look at surveys and studies around the world, Canada repeatedly is named the most tolerant country on the planet. So it's something there just doesn't add up. So we need to acknowledge we have problems. We have problems with racism. We have problems with socioeconomic divides. We have discrimination, significant discrimination in the past against our fellow Aboriginals, our fellow Black Canadians, etc. But to come and say that in 2024 we are a country that's a racist white supremacist country, that's just not true. So so it's a really not a good starting point. Oh, there's my daughter. Okay, say hi, Mila. Okay, so there's some of that. Now, the heroic college is borrowing language from ideologies and intellectual frameworks such as postmodernism, critical social justice, and others, which I won't go into much details, but I do have some I see a lot of problems with these ideologies and these frameworks. They're not necessarily empirical in nature. Their principles are maintained despite their being either demonstrably false or unfalsifiable, right? These ideologies are obsessed with identities and physical traits rather than ideas, truth, and merit. They deny the existence of objective reality, which doesn't work really well in medicine, does it? Make the claim that claims to truth are merely claims to power. So again, every time you try to make a truth claim, at the best of your ability, then they say that that's a claim to power. They consider lived experiences and subjectivism as basis of knowledge. They reject that a theory can be proven or disproven by the empirical process. Well, that's a problem, right, in science and medicine, because empiricism is really important. They do not allow corrections from the outside, not really open to debate. We've noticed that last few years, every time you try to engage in debate, etc., it is sort of it feels like there's a bit of cancel culture. They're very closed. They don't allow you to question their principles or their tenets, and that's a problem. And then they kind of deny that members of different groups can truly understand one another, and that's really sad, right? You know, I went skating today for the first time in my life. Kind of a white thing to do, isn't it? And you know, we're in this place, and it's just a beautiful place. You know, people from all different colors and backgrounds hanging out. I had a disabled gentleman who said, "Why don't you, push me on the wheelchair on the ice so you can get good at skating, and you can also carry me around." And I had a wonderful time, right? But you know, people of different backgrounds hanging out, having a great time, enjoying each other. So you know, it's too bad that these ideologies deny that members of different groups can truly understand one another. And some of the downsides I see with the proposed changes that are coming from the Royal College, I think there's going to be further division and polarization. There's going to be degradation of standards, and you really don't want degradation of standards in medicine. And again, in medicine, what we want to do is just keep improving standards, right? So we certainly don't want to see degradation, but we actually want to continuous improvement. We're going to see discrimination if we implement some of these policies that are being proposed. I think it really distracts us from complex solutions to complex problems. And it's going to hide, in my opinion, also like it's going to hide poor policies and weak leadership. You know, so for example, you know, we have in medicine right now lack of nursing, lack of beds, lack of innovation, cancel ORs, etc. And you know, now the leadership wants to talk about DEI instead, and sort of hide the really complex structural issues that are necessary to provide good care. And I think just lastly, before I go, just because I'm from the Middle East, I just, you know, it's been a sad few months over there with the Palestine-Israel situation. And I don't take any sides, to be honest. It's very complicated. I don't pretend to know too much, to be honest. Very complex situation. But what we saw with the DEI ideologues was a celebration of the terrible attacks that happened October 7th. Because when you look at the world through a very simplistic black and white lens, oppressor versus oppressed, you're going to celebrate that kind of event, right? So you shouldn't be celebrating October 7th, neither should be celebrating you know, the deaths of innocent children and women from the Israeli bombings, right? It's all sad all around. What you want to do is look for complex solutions to complex problems. I'll stop there and let the others speak.
All right, thanks, Pooya. From there, we're going to move to Martha. Martha, just to kind of segue a bit off what Pooya is saying. So we have not a great history when we focus ourselves on equity rather than excellence, rather than competency. When we prize equity above all, I think maybe it sends us to a dangerous place. Is that your concern? What is your concern with this?
I mean, I was actually, I think, like a lot of us, I was a little bit shocked actually when I saw this, because in medicine, medical excellence and professionalism and skill, I think, is what most physicians would expect from ourselves, but it's certainly, I think, what our patients expect from ourselves. And you know, EDI or DIE, whatever you want to call it, you know, I see different versions of it. You know, the words sound harmless. You sort of say diversity. Well, who can be against diversity? But what does that actually mean? And it certainly, if somebody says to me diversity of opinion, diversity of viewpoint, openness to different ideas, well then yes, I'm all for it. But if diversity means picking people based on physical characteristics and not their competence, then I have a lot of problem with that. And you know, when you talk about equity, I'm old now, and when I was training, it was equality. It was equality of opportunity. It was making sure that people had a chance to excel. But the expectation wasn't that we would all end up in the same spot. And equity seems to mean that everybody's got to be the same. And I this is really problematic. There's sort of obvious examples where, maybe somebody would like to be a pro basketball player. They're not going to be a pro basketball player if they're short. That's just the reality of it. And it's the same in medicine. Everybody should be allowed to aspire to get the education to get in, but people have different skills. They have different competencies. There are some physicians who are exceptionally skilled with their hands and they're superb surgeons. Not everybody is going to be able to do that. And we have to allow for excellence. We have to sort of accept that there are differences and celebrate those differences and let people work together with those differences to have even better outcomes. And so the term equity, where it sounds, it's hard to argue against, words that sound great, but you have to drill down to what this means. And so I think equality and giving people opportunities, 100%. And if you have unequal outcomes, we need to go back to the roots. We have to figure out why, where the barriers are going back. But and again, it's very complicated. One of the things that I'm seeing that Pooya sort of alluded to, is that instead of actually getting rid of racism and inequalities, we're actually, these policies are, for better or worse, exacerbating these. I mean, if you've had issues with racism in your society, which I think nobody's going to deny that there have been historically huge problems with this, and that there are still issues to confront, but you don't fix racism with racism. And if you are adopting a system that systematically discriminates against people who are presumed to be white, whatever that means, or Asian, then that's racism. It's just racism. And if you're discriminating, you're discriminating. And it's just fundamentally problematic for me to bring in a system that's replacing one set of bad policies or inequalities with a new set. So I'm not sure, sort of a little bit off topic of equity, but it's a difficult term to come to terms with. And if you're going to hire somebody for a position, I think there needs to be really clear expectations. And my expectation of a physician, or my physician, and I think this would be true of the vast majority of our patients, is we want somebody who is skilled, who's professional, who's clinically and professionally competent, who's compassionate, and who you can trust. And if they don't have that, then you can, or if we have people going through medicine who aren't capable, then we can judge them. But if we're hiring people based on their ideological beliefs, if we're hiring people based on or selecting people based on not merit, but these sort of soft, ideologies, how do you judge them? And in the nicest sort of way, how do you, if they're bad doctors, how do you replace them if they weren't hired for their competence in the first place?
Well said. Thanks, Martha. From there, again, I'm going to segue a little bit by maybe mentioning a great quote, which I think comes from Solzhenitsyn. He says, "If we're free, we're not equal. If we're equal, we're not free." And that gets a little bit into this issue of equity versus equality. And Roy, do you think it's possible to, what would I say? Do you think it's possible to have the best potential medical education system if our primary goal is actually equity? Do you think that it's possible to have a really good medical education system and produce equity at the same time?
No, I don't. I agree completely with what my two esteemed colleagues have said. I was born in India and arrived in Canada at the age of 2. So I arrived in a very different Canada than today. We moved into a neighborhood where we were the only people of color in the neighborhood. But I really never experienced racism to any great extent. I can sort of count on the fingers of one hand the sort of episodes of so-called racism I experienced. And so I've always thought of Canada as a very open and accepting place. And, on worldwide surveys, you see that again and again. So I don't quite understand this tendency of Canadians and other Westerners to beat themselves up all the time. Yes, there have been problems, but I think we've worked hard to try and get over those problems. And this seems to me like we're going backwards, not forwards. The whole concept of DIE, and it's not a coincidence that it spells out die. Is to divide and somewhat to conquer. You have a list of people who are oppressors and a list of people who are the oppressed. And the more oppressed you are, the more we're supposed to give you an upper hand. And that seems like a terrible way to right the wrongs of the past. It basically is a way to cause more wrongs of the future. They're white and people are white adjacent. So people from my community and Chinese people are supposed to be white adjacent because, of our abilities to study hard and get into certain professions. I think that what we need to do is work for excellence in medical education, which is what our patients want. I mean, I don't know whether, if you advertise that you're the best at social justice, that you're going to get better patients. I would like to know that you're a good diagnostician, that you're a good clinician, that you know what you're doing when you're coming to treating me for my health, which, after all, is probably one of the most important thing that we have, our health. So, and then to say that this is going to trump the clinical aspects, and we're going to put this in, if we start doing this in other fields, I mean, this DIE stuff is seeping into our other faculties, including the sciences like engineering. I'm afraid our bridges are going to fall down, and we're going to be, we're going to be much worse at the things that we're supposed to do well. So, it's interesting that a lot of the tech giants that started all these DIE programs in their milieus have started decimating those programs because it's created toxic work environments. And I can see this creating toxic work environments. The other thing is, we're now moving towards competency-based medicine for licensing. And how are these competencies supposed to be judged? I'm supposed to judge you on how much of an activist you are. We're supposed to judge on how anti-racist you are. I mean, it all sounds a little bit absurd. I belong to an organization called Do No Harm, and we actually put in the Royal College asked for commentary, because this is still just a position paper. It's not the final position paper, and hopefully they will listen to a lot of the commentary. We sent a petition in with 300 names of health professionals objecting to this policy. And I'm told hundreds of others have also sent in comments to the Royal College. I don't think this is a good way to perfect medical education. In fact, I think it's doing the opposite. So I hope that the Royal College will listen to its members and will rethink this whole project, because I don't think this is going to actually improve medical education, and I don't think we're going to get the best doctors by doing this. So it's time to have a rethink of this whole project.
Thanks, Roy. I'll kind of throw it out there. I know, at least I know that Martha and Roy, I believe both of you have been fairly involved with teaching, as have I. And boy, I can't speak for you, but I'm presuming you're probably in contact with medical students and residents. I know having been on a curriculum committee, one of the big problems we had is that we're trying to teach an increasing flow of what I'd say is basic medical knowledge, like the CPS, the Compendium of Pharmaceuticals in Canada, that had every drug in Canada that was used. I looked at the one from 1967. One of my mentors showed it to me when he graduated. It was like about 100 pages long, maybe. And now, like you guys will all know, that they don't really print it anymore, but when it was the last printed a few years ago, it's the size of the New York phone directory, right? So there's a lot more complexity to medicine. We're struggling to teach even the basics of the diabetes care. How do we treat heart disease? What are the basics of antibiotic therapy, et cetera? I guess one of my concerns, and I'd like to hear you guys sort of speak to this as you can, is I'm worried that medical education is a zero-sum game. It's not that issues of, what would we say, social wellness are not important. It's just that when we start to teach them, do we not displace some of the kind of the harder concepts? Do we not dilute the rest of the medical education or minimize it? Is it a zero-sum game? Do you guys want to speak to that, Martha?
But we're sort of talking about that right now. It's a decision. It's sort of the crux of this is what's important. And I guess what we're saying is what's important is that core medical knowledge. It's that clinical competence. I personally, for example, think anatomy is incredibly important. I'm an infectious disease physician, but how on earth do I understand what's going on with my patient if I don't understand the anatomy and the physiology of that person, if I don't understand what's going on in the body so that I can figure out, what or how an infection may be affecting somebody, if I don't understand how the drugs work in that person. And I think that's what the patient wants from me. I don't think the patient cares where I was born or what languages maybe languages, but they don't care about politics, they don't care about my religion, they don't care where I was born. My background's not that important in that setting. What's important is that I'm competent, that I'm empathetic, that I try to sort of actually deal with the human being in front of me and deal with the human being in front of me in a non-judgmental way. And I say that because my patients, like we're talking about this in terms of sort of selecting doctors with this whole EDI or DIE thing, but we can't judge our patients that way either. I'm not going to judge my patient on the color of my patient's skin or their political beliefs or their religious beliefs or their ideologies. That person in front of me is a human being I'm treating with respect, and that's it. And that's that individual encounter. And to get back to your question about sort of education, I don't want to spend time discussing somebody else's ideologies. That's not what's important in medicine as far as I'm concerned. And I think true of a great many of us. And so when we talk about medical education and CanMeds, the decision is, what are the core competencies that a physician needs to have? And I guess what we're saying, or some of us are saying, is that anti-racism, whatever that means, when you think of it as some sort of structural thing that permeates all of medicine, is wrong. Clearly, we should not be racist in our patient encounters. That's kind of core knowledge. We know that. But to take away from medical excellence, from medical knowledge, to focus in on, there's one of them, I wrote it down and I already forgot what it said. Something about planetary health or something. Like, I don't have any problems with planetary health, and I think that it's really important, but this is not the job of medicine. Like, I'm sorry, but can we stick to medical competence?
I'll just piggyback on Martha said, and I agree with what she's saying. First, I'll state that medicine is getting increasingly complex, even in my own world of anesthesia, which, to be honest, that hasn't changed as dramatically as some other fields like oncology, etc. But there's always new findings, new medical literature that emerges. Now they're overlaid that with artificial intelligence, big data, etc. And the doctor of the future is going to have to know a lot to be able to provide top care medicine, not mediocre medicine. In my own field, I have to keep abreast of sort of the new articles, etc., that come out to ensure that I'm giving evidence-based care to my patients, and it requires me to read a lot of papers and to employ new techniques to deliver anesthetics, etc. So yeah, you're right that it is a zero-sum game and there's only so much time. So you don't, although the biopsychosocial aspects of medicine are important, and the health advocate CanMed's role that is in the 2015 framework is very reasonable and should be taught to some degree, we really cannot decenter medical expertise, and medical expertise is becoming more and more important as medicine gets more and more complex, right? But what we're seeing here with this new framework is it almost sounds like they're trying to take physicians and take them from that core principle of medical expertise with the other CanMed's roles, like health advocate, which I agree with, and he has good things in there. In the 2015 document, they talk about trauma, racism, etc. Those are things we do consider when we talk to a patient, but they're trying to take us from just considering the biopsychosocial aspect of an illness when we're dealing with a patient in front of us and turn us into an activist. And that's not what physicians are. We're not activists, right? We're physicians, right? So when they introduce terms such as anti-racism, anti-discrimination, anti-decolonization, etc., this is activist language, and I'm not going to take any stance on it one way or another. I don't generally agree with some of the stuff in those ideologies, to be honest. But they have their place, and they can make their arguments, and we can engage in debate and move from there. But I don't want the physician to become an activist for those ideologies.
Yeah, I echo my colleagues' comments. I think that we should be an advocate for our patients, but to generalize that to people in general, we are not activists. We are physicians, and the medical knowledge is. When I started, I'm an endocrinologist. When I started treatment of diabetes, had insulin and a couple of drugs. It's now exploded, and I think it's more important to know about all of the new treatments, and the way we treat people to make their lives better, to lengthen their lives, and to make their lives better. And I'm not at all sure that any of this is actually helpful in that. And the way we teach medical students, to teach them to be activists will take away from teaching them to be good doctors. I don't think this is actually a way to make good doctors, and I think that's supposed to be our goal. And I've always thought of the Royal College as encouraging excellence in medicine, and I'm actually very disappointed that this is going on.
If I can just use the recent events at Harvard, if I can just use that as an example, so Claudine Gay was the former recent ex-president of Harvard, and this is the most prestigious university in the world, right? Including in medicine, and she was recently found to have engaged in dramatic amounts of plagiarism in her scholarly work. So how did she go from being a serial plagiarist? And that, is really disappointing to see in someone in that position. Actually, it's disappointing to see from anyone, because small amounts of plagiarism will get you in a lot of trouble just as a student. Not only did she plagiarize, but she also had very limited number of publications, something like 11, I think it was maybe up to 17, but maybe 10, like 11 papers, which honestly,
I think it's 10 or 11.
That is a very limited portfolio for someone who's a president of the most prestigious university in the world. And when she was exposed as having engaged in plagiarism, which is unacceptable for somebody who's the president of Harvard and having had very limited sort of academic portfolio, in her resignation letter, an op-ed in New York Times, she went on to call everybody racist, right? So there's this sort of this is what this ideology does, right? It installs someone like her at the helm of the most prestigious university in the world, and then when she resigns because She has been exposed to have engaged in plagiarism and poor scholarly work. Then she goes on to call everybody racist. And so that this is not what we want in medicine in Canada.
So just to make a comment on the president of Harvard, there are many competent Black academics who could have taken that role. Condoleezza Rice, for instance, many others. But the problem is the diversity they seek is not diversity of opinion. It's not diversity of thought. It's sort of uni-thought, and that's what they're encouraging.
Yeah, okay. I'm going to throw in a couple of thoughts here. Maybe you guys, if you want to comment on them, that's great. And then I'm going to bring up a couple of questions from our live stream. I'm going to put a big plug in for Aaron Cariotti was one of our speakers at this year's Free Speech and Medicine conference by Zoom. Unfortunately, he got invited to Jordan Peterson's ARC conference at the last minute and had to bail on coming in person. But his book called The New Abnormal, I really like, and I'm going to paraphrase a whole book into just a brief few sentences, but basically he talks about the rise of Nazism, and doctors were among the most enthusiastic part of the population in terms of adopting Nazism. And he basically, what he concludes is that there in a doctor-patient encounter, there's room for only two people and their thoughts and ideas, the doctor and the patient. And sure, the patient's family can be a part of it, but it's really the doctor and the patient. The minute that you bring a third party in, and that third party being the public good as defined by experts, then suddenly everything gets upended. Because when you have a 92-year-old diabetic lady in your clinic and you're saying that the COVID vaccines are going to save everybody, but you happen to be white, so we can't vaccinate you yet because we're going to vaccinate Indigenous people first, which actually did happen in Canada, then we've now run into a problem. Because if somebody believed that those vaccines were actually helpful, and we know that the age gradient was 1,000 or even 10,000 times in terms of risk for old versus young, why were we vaccinating young people of one race ahead of people, elderly people of another race? Well, that's what happens when you allow that third party into the doctor-patient relationship, according to Aaron Cariotti. And in a way, perhaps this new CanMeds framework is actually is concretizing that. It's actually saying, yes, that is the way you have to practice. Do you guys see it that way? Sorry, silence. Maybe I've said too much.
No, you have to think about the I actually agree with that in the end, it's sort of, the physician and the patient. And I guess what I was thinking, sort of you moved into, is that, respecting individual decisions is obviously really important for the patient and all that. I guess I was my mind was going a little bit different way. Is I don't think it's a secret that EDI or DIE, as whatever you want to call it, is actually very controversial. It's in fact not an ideology that's shared by everybody, and to impose it on society and to impose it on medical physicians is imposing imposing sort of a sort of, but it's also imposing on our patients, and that's sort of what you're saying. Like, we're basically now imposing a particular school of thought on patients, which I think is wrong. I don't think that politics and ideology and religion should be part of my interaction with individual patient. And I don't think that if I have, quite frankly, let's be blunt, a white male, because white males are kind of the bottom of the totem pole of EDI, that patient deserves just as much respect and care and attention as any other patient I see. And I don't like this identity. I don't like identity politics being brought into this. And yes, it has an impact on health, on allocation of resources, and these are complicated issues which deserve open discussion. This comes back to what I said at the beginning about diversity. Diversity, quite frankly, means diversity of thought, diversity of opinion. It's open debate. It's open discussion. It's being open-minded to different ideas and ways of doing things. And there was a comment earlier about our healthcare system is failing, and yes, we're having a lot of issues. And what I'm not seeing right now, for example, is open-minded conversations on the healthcare system in terms of maybe ways that we can change it or ways that we can amend it. We're not open-minded as a country at the moment at looking at systems in Sweden or Switzerland or any other country that's got different types of a healthcare system and how we might be able to restructure this. And I EDI, I mean, that's not going to help our healthcare system. So it was a little bit off topic from what Aaron said, but politics shouldn't be part of medicine like this.
I'm just going to throw in something else too. It seems like I've heard identity politics described as a revenge-based system, a revenge-based ideology. And one of the things that people on the side of the DIE requirements kind of keep pointing out is disparities. But one of the disparities I don't hear much talked about is med schools in Canada are about 60-40 female male and majority female for 25 years or more. The other issues are things like Nigerian Canadians get into med school at very unusually high rates. You East Asian people, I don't know what it is you do at school, but you guys get into med school at unusual rates. I know the data from the USA better, but in the US, white people in medical school are kind of at the right amount. There's the right amount of them in. There's too few Black and Indigenous people. The problem is that it's Asians and East Asians and people like Nigerian immigrants and whatnot who are skewing it. They're getting into med school in unusual numbers. So it doesn't really seem like, I don't think the goal really is equality per se, because if we were looking for equality, we would have programs to get more men into med school, would we not?
You see, that comes from the hierarchy thing, and the hierarchy is white males, and unfortunately they also seem to think that Jews are at the lower end of that hierarchy. And we're seeing a lot of that on campuses today, that people are doing unspeakable things to some of our Jewish friends. And I've always said that the Jews are the canaries in the coal mine, because the DIE people are coming for all of us at some point. I really think that I don't care how many of each type of person go get into med school. I want the most competent people to get into med school. I want them. I want to be looked after by people who know what they're doing. I mean, I'm getting older, and I'm hoping to find doctors that will know what they're doing. And I'm not sure, assigning people by race is a problem. The other problem I have with affirmative action for people going to higher levels of education, the problem isn't usually the higher levels of education. The problem is usually kindergarten to grade 11. I mean, the lower levels of education, teaching basic reading, writing, and arithmetic skills. And, in a lot of the communities we're talking about who have problems with equity, we should be doing a much better job of that. And so if we actually looked at what the problem was to get more people of different ethnicities and into medical school, we should probably look at teaching basic skills better, rather than getting them into medical school.
Yeah, so I agree with Roy there. Sorry to interrupt there. I think again, like this is where it becomes counterproductive or more of a distraction. So let's say you implement a DEI program that tries to create proportional representation for professors in a certain field. And let's say you end up doing proportional representation there and get make sure that they match the societal percentages of each color of the people. But the issue is, okay, so now 99.9% or more people are not professors. So have you helped the 99.9% of people who are not getting childhood nutrition or early education? Or are you really creating an uplift for that minority group? No, all you're doing is maybe placing a couple of extra professors from that minority group into a university. But you're not. Again, we need complex solutions to complex problems, and these are superficial solutions that are like maybe just like lipstick or band-aids, rather than true solutions that actually improve people's lives. It is true, as I said earlier, this all starts with kernels of truth. Uh, we do have socioeconomic disadvantage. We do have minority groups that require better healthcare, better education, better nutrition, access to this or that. And that's where the solutions need to be, not in DEI policies at some university.
The education question is a really interesting one because the closures, the school closures that happened in some countries like Canada as a result of the COVID response probably had one of the most catastrophic, long-term impacts on kids who were already significantly disadvantaged. And that, if somebody wanted to have the single most important impact or sort of long-term impact you could have on some of these groups, it would be to go straight to those schools and look now at the degree of astonishing chronic absenteeism, what's happened to all those kids who are just gone now from the education system. I mean, this is a devastating long-term impact on a group of kids who are the kids that were, if you are thinking about sort of equity or equality, that these are the kids who were the single most disadvantaged already in society, and we've now essentially probably destroyed their futures. And I don't know if anybody is from the Toronto area. I mean, I'm not, but I live in Hamilton, so close by. But the Toronto District School Board, for example, last year got rid of enrollment into sort of specialized or advanced classes because it wasn't equitable. And so, I don't know, we used to have basic, normal, and advanced classes for example, in math. And so kids that showed an advantage or who showed a predilection, who were smart in math, could take advanced classes so that we would build on competencies that kids already showed. Well, like, instead of actually enhancing that kind of program and looking at the children and thinking how you can actually help their future, they're dumbing it down. They're getting rid of all of that because it's not equitable. And it's not quite what you were asking, but I do find that if you wanted to worry about sort of the inequities in society, this isn't, putting this into medicine isn't going to do it. But if you were going to talk about educational access of kids, that would make a big difference.
Yeah, so Martha was a hero of mine because she fought really hard to push against school closures. Her and I got involved a little bit too. We wrote a few op-eds about this topic. And what's interesting is that the people that were pro school closure, who wanted to close schools for a long time, came from the same sort of political spectrum that's pushing DEI. And guess what? School closures really hurt, and the data is clear on this. Even the sort of more progressive publications, outlets have now admitted this. It really hurt kids that were at a socioeconomic disadvantage already, which were minority groups. So what did they do? They worsened their educational outcomes by these school closures. And these were the same people who pushed for this policy came from sort of the DEI camps, right? And that's really unfortunate, right?
Maybe I'm gonna move us along a little bit. You can see a little while ago I popped up this question from Dina Churchill. Thanks, Dina, for joining. And I thought this was a good question because there's always this let's discuss what's wrong, and many of us can agree on it. It's a bit of a love in on terms of what's wrong, but what can we do to actually fix things is part of the question. And we physicians can kind of fight as we can from the inside, I suppose. But what about somebody from the public who's concerned that their physician 10 years from now is going to be less competent because of the changes in training? What can they do?
The Royal College had asked for feedback on this. Unfortunately, the date for the feedback to these new proposed changes was December 31st. I actually just checked before we came online, and it's like it's just closed. You can't access the document anymore. It will be fascinating. I find the idea of feedback sort of a kind of an interesting way to do it, because of course we don't get to see the feedback. And so whether they actually release all of the response they got, or whether it's selective release, maybe I'm being a bit cynical. But I think even now it's not too late to write to the Royal College and to write to actually the provincial colleges. Like in Ontario, the College of Physicians and Surgeons of Ontario is also proposing putting, requiring this as part of a professional competence for physicians. And I think that probably the two, that's certainly one way to do it is to write to the colleges even now. I am not a particularly politically savvy person, and I don't know whether, to what extent politics can make a difference, but I do, I know, but I do think that these are things that shouldn't be ignored. Yeah.
Mm-hmm. Yeah, I agree. So maybe to sum that up, it is worth the public bashing away directly at the college. I think that helps, because physicians feel like there's some physicians are brave enough to speak out, many are not. So if you're one of those people who sees that there's something wrong here, I think it's incumbent on you to speak directly to the college. That's my take on things. And do either one of you guys want to comment before we go to another question/comment?
I think writing letters to the editor, talking on the radio for talk shows when these topics come up, I think the powers that be do listen to those kind of things. I'm not sure how much the Royal College listens to those kind of things. I think, maybe you should tell your doctors they should write to their colleges and the Royal College as well. Your patients should make it known that they want competence, and I'm sure that's exactly what they want. I sometimes that's a little bit hard to do, but the colleges are supposed to represent the public. So if you write to your college and tell them that you don't think this DEI is actually good for doctors and good for the public, I think they will listen.
Mm-hmm. I'll just throw in a comment too, just to differentiate, because somebody had asked this question to me before. There is a difference between the colleges. So there's a provincial college and territorial colleges that license doctors, and the Royal College is actually a national body that sets standards for education for each specialty. So if you want to be a neurosurgeon, what criteria do you have to meet? Well, that depends on the Royal College. It's a national body. This specific problem we kind of launched into this issue today with what is from the Royal College, so the national body. So if you want to address this medical education issue, you probably want to hit them. If you don't want to see it leak into your licensing recommendations, it's worth contacting your provincial college as well. So probably CC both is the answer. I'm just going to move on here. So this is from a physician listener, Dr. Les out in Alberta. Hi. One of the big questions is, why are doctors at large so silent on this? Are they not paying attention? Do they not realize the dangers inherent in this approach? Do they not care? You guys have any thoughts?
Well, I think that the colleges have very poor. One of the reasons that Chris is one of my great heroes is that he put out this free speech in medicine. The colleges are very good at silencing their critics by saying it's not professional to talk about such things. And some of our colleagues during the COVID era have lost their licenses for speaking out. So the colleges, the regional licensing authorities have been quite good at silencing their opponents, much to the detriment of medicine and their patients.
Mm-hmm. You guys,
Yeah, there's definitely some degree of cancel culture and censorship going on. People are scared to speak out. I spoke to some physicians recently who, again, as I said earlier in the conversation, said that we have children and mortgages, and so we don't want to speak up. And that's extremely disappointing and saddening for me. I'm not speaking about the physicians, about the culture that we're in, that people have to feel this way. Again, this is not the country I moved to. It's extremely dangerous that healthcare professionals aren't able to speak their mind, because if you don't speak in your mind on this topic, maybe you're not speaking your mind on other topics as well, like shortage of beds or shortage of nurses, cancellation of ORs, etc. Because you live in a culture of fear, and that doesn't belong in this country, right? That belongs in the country where I came from. That's where that is. Not shouldn't be here. So people should be able to speak. But I do encourage physicians to speak up. To be honest, I think it does make a difference, and I don't think they should live in so much fear. Uh, at the end of the day, we do have some degree of free speech and free expression in this country, and lawyers are able to protect you if need be. And if everybody spoke up, it could make a big difference. We can unite in bigger numbers. And again, speak with humility and with respect, and using gentle language, and using the truth as you see it, and hopefully can move the conversation along.
There's a sorry, Martha, I'll just cut in 1 sec. There's a concept in game theory. I can't remember the exact name, but it's something like the collective response paradox or something. It's this idea that you can have 95% of people who agree with one view, but if they're all afraid to speak, then the 5% kind of get their way. And I feel that's what's happening. When you talk to most people, doctors or otherwise, I think they get these issues, or at least to some extent. And very few are like highly supportive of DEI and all its manifestations. So I do think I read the Gulag Archipelago and other books, and I think to myself, we've really developed into a very soft society of cowards. When the people spoke out in other societies, they risked hanging, death, torture, the death of their families, and they spoke out. And we're risking, oh geez, maybe I'll have to switch job and live in a smaller house, and where a lot of physicians are using that as an excuse. I couldn't possibly speak out because there might be a repercussion that I wouldn't like. And I don't really buy that. Worst case scenario, let's say you do lose your job, it's not like there's not other jobs out there. So that's my take on it. Is people need to be more brave. We live in a pretty open society. We don't get shot for our views, and you got to say what you think. Anyway, sorry, Martha, I cut you off.
Actually, I was going to say, as somebody who did speak out during COVID, I started speaking out against lockdowns in May of 2020. So I was a pretty early objector. And I was a very early advocate for what I call a balanced response. It isn't actually that easy, but I think that it's a little bit what Pooya said. You speak with respect. If it's a personal opinion, I say it's a personal opinion. If I've got data to back up what I'm going to say, I've got data to back up what I'm going to say. But the culture of conformity and of manufactured consensus is pretty powerful. I was surprised at how many people would say to me that they agreed with what I was saying, but were too scared to speak out. And like Pooya says, it was very disappointing. More specifically, though, I think some people, yes, are scared. I actually think on this particular one, I don't know that the college has communicated that well, quite frankly, to all its members. And I guess I would challenge the college, if they're that confident that this is the way that medical education should go, it should be put out to an open vote to all physicians in the country. Like, this can't be something that's just imposed because of their little sort of groups that are put in place, the focus groups, and they can say they've had public consultation, but in that case, every single letter or every single response they got should be made open to everybody. It shouldn't be a secretive process. We should be allowed to see what the feedback was, and quite frankly, it should be put to the vote. This is a massive, huge change in the focus of medical education, and quite frankly, the direction that medicine will take in this country. And it shouldn't be done without not, I don't know how many people on this who are listening to this were aware of it. I know that there was one op-ed in the National Post that was talking about it. There's some stuff, but the more openly it's discussed, and the more that people are aware of it, and the more feedback, like I go back, the more diversity of opinion that we have on this, I think the better the outcome. But yeah, if people are not aware, they're not going to know. And I personally don't think that it's been that well advertised. It's sort of a bit of a sneaky. I didn't get an email from the college asking me to put on this. I found out of it because somebody, one of my colleagues, told me about it. And so it's such a fundamental change to the direction of medicine. If the college thinks it's a good thing, then let the sunshine, shine on it. Let the sunlight shine on it. Make it wide open and let us all vote on it.
Yeah. Well, listen, as I think looking at the time, we're a little over an hour, so I think we should probably start to draw things to a close. We'll perhaps go in reverse order. Roy, since you were last the first time, what does it say in the Bible? The first shall be last, last shall be first. So you're leading off as we give our closing statements.
I don't think the DIE framework that they're proposing is actually helpful to medical education, our students, or our patients. And I think the Royal College should strongly reconsider what they're doing. I think that a lot of their members have issues with this this framework, and I'm hoping it's only a framework and that changes can be made. But unfortunately, I don't think the Royal College has been transparent enough, and I'm not completely hopeful.
Martha?
Yeah, I mean, as I say, I don't think this should just be imposed from above. If they're going to do this, I think it should be an open vote. And my opinion I'm going to actually end with what I would hope would be the direction that medicine would take, and that the direction our universities would take. And it's actually from Martin Luther King, his "I Have a Dream" speech. I have a dream that my 4 little children will one day live in a nation where they will not be judged by the color of their skin, but by the content of their character. And I actually wish that that's the direction that we're taking, that we're judging people on the content of their character and not on their perceived race or anything else. And that would be the direction I would hope we would take.
Wonderful. Pooya?
We certainly have some minority groups in North America do face certain disadvantages that are real and they need to be addressed. So these are, again, complex problems that need complex solutions. However, I don't think the DEI ideologies are the solution to this. I see these ideologies creating more problems such as division, polarization, degradation of standards, and new forms of discrimination. So I like us to think a bit more deeply, not so superficially, not so black and white. Go back to old school liberal principles, empiricism, meritocracy, and sort of a more humanist approach, and hope that we can solve our complex healthcare needs as well as some of the complex needs of our disadvantaged minority groups.
Lovely. Well, listen, thank you guys very much for joining me and for talking about this. I know it's difficult, especially for you, I suppose, Martha, you're on the cusp of retirement, so not so much of a consequence for you. But I know as a practicing physician, it's always hard to say anything because you never know what might happen. So thank you guys for your bravery and your honesty here tonight. I'll sort of leave you with my final thought, and I'm glad you mentioned Martin Luther King. I really do look at this. Do we go the enforced equity route, or do we try to promote a society with equality of opportunity for people? And I think there's two quotes that best highlight that. The first quote is Ibram X. Kendi, who's it's kind of the main driver behind this movement towards more and more anti-racism, more and more DIE. And he says, the only solution to past discrimination is present discrimination. The only solution to present discrimination is future discrimination. So he looks at this as being a never-ending process of discriminating against people who have had what he perceives as an unfair advantage in the past. And it really reminds me of, I think it was Krishnamurti who said, an eye for an eye until the whole world is blind. It just feels like we're on that path. So I'll leave us with a much better quote, which I think is the actual way forward. Martin Luther King said, and I'm just going to take a little piece of his quote, but he said, only light can drive away darkness. Only love can drive away hate. We can't use negative things like discrimination and giving certain people, a leg up by putting others down. We can't use that as a positive way forward that's going to get us anywhere good. So I thank you guys very much for talking to us tonight, and thanks everyone for joining us. I'm glad the tech didn't totally fail anyway. This is our first time doing this, so I can now breathe a big sigh of relief.
If I can just add one thing, Chris, thanks for organizing this. I really appreciate it, and thanks for the other participants for expressing their views, and thanks for the MLK quotations. Those are great. But one thing about Kendi, as you know, his anti-racism research center has come under investigation for having wasted millions of dollars and not having produced the research that had been promised. So again, we're being given false promises by these leaders in the DEI world. But I just wanted to highlight that, and people can go read about that. It's all over the news.
Lovely. All right. Well, thank you all. Thanks everybody out there in internet land. Thank you to the guests, and we'll see you in a few weeks with Dr. Gad Saad. Stay tuned. Bye-bye.